discussing something regarding the pregnancy and heart disease. To begin with, a few points regarding the physiological changes that happens during pregnancy that we should remember. This is the common questions asked. They are like the plasma volume in pregnancy, it starts to increase at 6th week of pregnancy, and it reaches its peak at second trimester at around 32 weeks. And the peak that is reached is 50% above the baseline. On par with the increased plasma volume, the red cell mass do not increase. That is, the plasma volume altogether increases to 50%, whereas the red cell mass increases by only 40%. And hence, there is a physiological state of anemia. And it has been found that there is increased demand for iron because of increased organogenesis that happens during the pregnancy. And it has been found that the increased demand for iron was found to be at 500 milligrams. So there is a net increase in volume of 50% from the baseline, which actually increases the cardiac output. And the cardiac output also peaks along with in parallel to that of the increased plasma volume. And it is around 32 weeks of gestation. It is at its peak. But the stroke volume peaks till 20 weeks of gestation, and later on the cardiac output is mainly taken out, mainly maintained by the increase in heart rate. That is, after 20 weeks to 32 weeks of gestation, whatever the increased cardiac output is taken over by the increase in heart rate. So the fourth important change that happens is decrease in systemic vascular resistance. And it is a normal phenomenon. It has to happen. And if at all it is not happening, there will be fetal-placental insufficiency, which we commonly see in patients with hypertensive heart diseases. So it begins to fall from 5th week of gestation, and there is a maximum trough at 20 weeks of gestation. And there is a fall by 35% from the baseline, and it remains constant till 32 weeks of gestation. And on par with this, there is increased oxygen consumption by the heart, and progressively increases by 20 to 30% throughout the gestation. So what happens during parturition? That is, during first stage of labor, the intravascular volume increases by 30%, whereas in the second stage of labor, on over this 30%, again there is an increase by 50%. And the maximum increase or maximum burden to the vascular system happens during immediate postpartum period, wherein 60 to 80% over the whatever has been added to the vascular system happens. And this is the time period wherein we can see maximum incidence of pulmonary edema in individuals who are predisposed to develop, individuals who are predisposed. And the hemodynamic burden on the heart lasts for up to 24 to 72 hours. And at least for a period of 48 hours postpartum, the patients has to be kept under strict hemodynamic observation. And why this happens is because of two reasons. One, that is because of the autotransfusion. That is, during each uterine contraction, it was found that 500 ml of blood reaches the vascular system. And the second reason put forth was that whatever the compression, external compression that is offered by the uterus, gravid uterus, is released, and the preload from IVC increases. So along with this, we should know how much amount of blood that that is lost during pregnancy. That is, approximately 500 ml of blood is lost during a vaginal delivery, and 1 liter of blood is lost during cesarean section. And when do all these hemodynamic changes revert to normal? That is, it was found that at 6 to 12 weeks postpartum, these hemodynamic changes, they revert to normal. This is just a table showing the it's a pictorial representation of what I have told. And moving on to cardiac disorders in pregnancy, the most common cardiac disorder encountered in pregnancy is hypertensive heart diseases, which counts to 5 to 10% of the cases. Among the remaining causes for cardiac disorders, in Western countries, it was found that congenital heart diseases accounts for remaining maximum amount of cases, whereas in non-Western population, it was found that rheumatic heart disease is more common. So before going into the details of the heart diseases per se, I just want to give a brief about a few things which have to be, which are special to this category of patients. That is how these patients have to be risk stratified, because these are the population wherein the hemodynamics are very much different from that of a routine population. So pre-conception counseling is required for patients with risk factors, or who are previously diagnosed to have a heart disease, or who have been diagnosed for the first time during pregnancy to have a heart disease. And for risk stratification, the minimum investigations that are required are an ECG, echo, and exercise test. Why is exercise test important, and where it is important is in individuals with valvular heart disease, the exercise test actually determines, for example, in patients with asymptomatic severe aortic valve disease, if the patients are asymptomatic with the exercise capacity of more than 80%, they can be safely allowed to go through the pregnancy, because the observed mortality in this group of population is less than 1%, and hence exercise testing is very important for risk stratification of this group of population. So the maternal risk factors actually have been studied, and the three studies which I want to mention here are like Carpet, ROPAC, and Zahara. And above this, the modified WHO classification also classifies pregnant women into 5 risk categories. So these were the predictors of events during pregnancy in women with heart disease, those being based on the patient history, any event of prior heart disease, or any cardiac event during the pregnancy, any cardiac interventions in the past, or what is the baseline NYHA class, and physical examination, important points being cyanosis and specific lesions imaging and delivery care. All these things I think we can go through. So these, in this manner, the patient has to be analyzed. And the most important thing that we have to be knowing about is this modified WHO risk stratification of mother. As I told, there are 5 classes, 1 to 4. One being those with uncomplicated congenital heart diseases, like small PDA or mitral valve prolapse. And here, what we have to remember here is that there is no detectable increased risk of maternal mortality or morbidity. Whereas in class 2, there is increased risk of maternal mortality, but the risk is small, but there is certainly some risk. And there in class 2 to 3, this is intermediate category, wherein there is moderate risk of maternal mortality. Whereas in class 3 and class 4, the class 3 being high risk women, why this is important is that they have to be followed up every monthly or bi-monthly, whereas class 4 are those individuals where pregnancy is actually contraindicated. And this group we should remember, because this is the group wherein they have observed very high mortality rates, as high as 30%. So I just want to give just a brief about the conditions here. Not many. They are like pulmonary arterial hypertension, isomangarization, severe LV dysfunction, EF being less than 30%, a previous history of peripartum cardiomyopathy with residual LV dysfunction, severe MS, and severe symptomatic aortic stenosis, whereas asymptomatic aortic stenosis comes into low risk category. And all these aortopathies, where the aortic dilatation more than 45 millimeters in case of Marfan's, whereas and more than 50 millimeters in bicuspid aortic valve, and the native severe uncorrected coarctation comes under class 4, wherein pregnancy is contraindication. So moving on to the risk categories, these were the registries or the studies which actually have categorized the risk associated with the pregnancy. And in the CARPEC, that is cardiac diseases in pregnancy registry, this was actually a study which was done in 600 pregnancies. And the majority of the cases here were congenital heart diseases. And what they have observed is that the average incidence of developing uh, adverse effects in patients with congenital heart disease who are pregnant, they have observed to be at 13%. And the most common adverse events were like heart failure and arrhythmias in this particular study. And they have scored uh, them into three categories. Those with a score of 0, with 1, and more than 1. Why this is important is that with with a single risk factor, they have found that the cardiovascular risk was 25%. With the more than one risk factor, and the cardiovascular risk has increased to more than 3 times. That is, it has gone to 75%. So I think we can go through this. And the Zahara registry or the study have taken the patients with congenital heart disease. It is basically a multicentric study which was done on 700 pregnancies, and they have actually charted down 7 parameters, and each parameter have been given individual points. It is a point risk score, and you can see here that when the lowest risk score, that is a score of 0 to 0.5, the cardiovascular risk was around 3%, whereas for a score of more than 3.5, the cardiovascular risk observed was nearly 70%. And this I have mentioned, the WHO scoring or classification. This is one thing which we should be aware of, that is a new branch known as cardio-obstetric team. Is important because in high risk pregnancies, I'll be coming to that category of patients later on. They have to be put under monitoring only with these group of individuals, that is the cardio obstetrics team. And what they say, it's a class 1 recommendation. And this team actually consists of obstetrician cardiologists along with maternal fetal medicine, genesis, anesthetist, pharmacist, and a nurse. What is important here is the treatment care has to be started with the pre-pregnancy counseling, and the patients has to be monitored during the counseling based on their risk level, and the delivery has to be planned, and the postpartum follow-up is important. This is the flow chart which has been mentioned by the recent circulation, journal in circulation. So these are the high risk patients which I have been mentioning. They have to be under observation by this cardio obstetric team. And these are the contraindications for pregnancy, which I've already mentioned. So what are the predictors of cardiovascular outcomes? And they were actually divided into maternal and neonatal events. Maternal events being a prior cardiac event, left heart obstruction, and NYHA class 3 or 4, reduced LV function, EF being less than 40%, and RV dysfunction, presence of AV valve regurgitation, and pulmonary arterial hypertension. And one important thing is that the cyanosis. I'll mention this in congenital heart disease topic. And the neonatal events being smoking during pregnancy, and again the maternal oxygen saturation, multiple gestations, and previous history of cardiac medication, mechanical valve processes, and any cardiac event during pregnancy, and even the necessity of surgery during pregnancy also accounts for highest neonatal or fetal bad outcomes. So who actually requires genetic testing or counseling? Patients with defined autosomal dominant disorders, those being hypertrophic cardiomyopathy and LQT syndromes. Since the risk of inheritance is 50%, they have to be subjected to genetic counseling. And there are also some guidelines given regarding whom have to be sent for genetic counseling. Those being, apart from those autosomal dominant conditions, they are like carrier status of hereditary pulmonary artery hypertension or pulmonary vaso-occlusive disorders, history of cardiomyopathy and channelopathies, congenital heart diseases, those being conotruncal defects, bicuspid aortic valve, and those with syndromic associations, usually with the iotopathies, they being Marfan's and Dajors and Williams, Agilis, Noonans, and Holterams. Just to specify, I mean, they have specified these to be definitely subjected to genetic counseling, and a family history of any of the above disorders should be subjected for genetic counseling. And fetal assessment, what has to be looked at? Mainly a nuchal fold thickness at 12th week scan, and it has been found that even in fetuses where the nuchal fold thickness was normal, the incidence of congenital heart disease was still high, that is 1 in 1000. And the sensitivity and specificity of 12th week scan to diagnose a case, to diagnose major congenital heart diseases being 85% and 99%. And in women with congenital heart disease, the fetal echo, which is done, there is a morpho scan, which is done at 19 to 22 weeks of gestation, usually diagnoses only 45% of the fetal congenital heart diseases. The remaining are still undiagnosed. So moving on to ionizing radiation. Why ionizing radiation is important in...
but that is the common time we do, no?
No, yeah, it is a common time we do, but
so
the same thing
I think
holds
most
good
of the
even,
case, by the time diagnosis happens, the 20 weeks will be over and MTP will be difficult to advise.
Basically, now the indications for MTP has been there are very few. Like if at all the congenital heart disease in a fetus, if at all it can be addressed at a single stage surgery, there is no indication like the fetus has to be aborted. Like only in complex congenital heart diseases like in HLHS or hypoplastic right heart syndrome and those conditions wherein the mortality associated with the procedure as well as the fetal outcomes per se are poor, they are actually recommended for abortion or termination. Simple BST, AST, even TOF, there is no indication for termination of pregnancy.
No, alla mouthika, if the parent doesn't want, andre?
If she doesn't want, I mean, that's what the termination is basically in the parents' hands. Like if the mother wants to continue the pregnancy, she can continue the pregnancy and later on can go ahead with whatever the outcomes. If at all she doesn't want to continue the pregnancy, she can terminate.
Terminate. No, there is nothing like it is illegal.
No, there's nothing like, no. We can give only the medical indications.
Medical. Okay.
It is again the individual decision. Like.
Decision.
Yeah. So why we have to know about the ionizing radiation is that because the many of the procedures which are planned during pregnancy was the recommendations were done based on the effect studies of ionizing radiation effect on the mother and also on the fetus. And what they have found is that there is risk for both mother as well as fetus during any stage of pregnancy. And as far as possible, we have to avoid a procedure during pregnancy. But in inevitable circumstances, the ideal period is the second trimester. And it has been found that the highest ionizing radiation to the fetus or the highest effects on the fetus are seen in the first trimester and least were seen in the third trimester. And if the fetus is subjected to a radiation dose of more than 250 milligrays in the pre-implantation period, what they say is till 9th day pre-implantation, there is a high chance of spontaneous abortion. And beyond 9th day, the risk gradually decreases, but the risk of congenital abnormalities increases. And as I think some of us, one of us have discussed the radiation effects. They are like stochastic and deterministic. And the deterministic effects, that is dose dependent effects, which they have found were like at a radiation dose of 100 to 200 micrograys, they have found there is a high chances of neurological abnormalities, those being intellectual disabilities and even malignancies. And the greatest vulnerable period for growth retardation was in the 8 to 56 day post-conception. And they have found that the incidence of microcephaly was more during 14 to 105 days post-conception. And the highest acceptable dose of radiation in pregnancy is 20 milligray, but even with that, there is high likelihood of childhood cancers. So what they say is, as far as possible, the radiation that can be allowed should be less than 10 milligrays. That is what the guideline says. And the radiation dose to the fetus should be as low as possible, acceptable, as I said. Some guidelines say it is 20 and some say it is less than 50 is also okay. But ideally, it should be less than 10 milligrays. And the mean radiation exposure to the unshielded abdomen is 1.5 milligrays. And what they say is only less than 20% of the maternal radiation dose reaches the fetus. Moving on to interventions which might be required in a mother during pregnancy, those are like percutaneous therapies. And the best time, I told, during the second trimester, and the ideal period is 4th month, where the organogenesis is complete and the fetal thyroid is inactive and the uterine volume is less. Hence, the accessibility for the catheters is good and the maneuverability is good. And also that, and there is other factor, that is there is a greater distance between the fetus and the chest. So hence, the 4th month of gestation is considered as ideal period for procedures.
Mautika
And what are
told
the menus? Yeah.
you were told 1.5 grays, no? That
Yeah.
with a shield. That is for what
Yeah.
procedure?
On an average is what they mentioned.
Okay, okay.
What are the menus that has to be considered to minimize the radiation dose to the fetus? That is, the first thing is as low as reasonably achievable. This is the principle, that is the Alara principle, what we generally have to follow for any other case. The same thing has to be followed in this scenario also. And others being, as far as possible, it is always advisable to go for an echo guidance, and the source should be as distant as possible from the receiver, from the patient, and the receiver should be as close as possible to the patient. And always use a low dose fluoroscopy. As far as possible, sun images have to be avoided, and even the number of frames has to be cut down. Always favor the AP projection view and avoid direct radiation to the abdomen. And what they say is oblique views have to be avoided. And as far as possible, always you have to use the collimator, and as tightly as possible, we have to collimate the area of interest. And as we know, the fluoroscopy time has to be minimized, and always use experienced cardiologist in the lab. That is very, very important. And the shielding, although it decreases the radiation to the fetus, but there is higher scattered radiation, and this has to be kept in mind when you are shielding the abdomen. And one thing important regarding the shielding of the abdomen is that the shield has to be applied both anteriorly as well as posteriorly. And during procedure, the anticoagulation is same as that what we do for any other procedure. And a brief about the cardiopulmonary bypass, which is used during the surgery. What happens when a mother is subjected or fetus is subjected to cardiopulmonary bypass? The maternal risk is same as for that of a non-pregnant woman, but the fetal risk is very, very high. It accounts to nearly 20%. And why this risk is mainly because there is decreased perfusion to the fetus during cardiopulmonary bypass, because usually they are put under hypothermic cardiopulmonary bypass, and hence for improving the fetal outcomes, the newer propositions have been like it is always better to use a normothermic cardiopulmonary bypass, and high pump flows as far as possible. Pulsatile perfusion is always advisable, and high pressure system should be used, and as far as possible, the bypass time should be cut short. And during the cardiopulmonary bypass, what has to be monitored? It is always advisable that whenever it is imperative that you are taking a patient for surgery which requires a cardiopulmonary bypass, it is almost always recommended that the time period, unless it is an emergency, the time period which is ideal to take up for a CBP is after 26 weeks of gestation. That is 26 to 30 weeks of gestation is the ideal period for a cardiac surgery, because this is the time where the viability of the fetus is achieved. And even though the patient has gone for a preterm labor, there is still chances to save the baby. And during the CBP, we have to monitor the uterine contractions and the fetal heart rate.
No,
So this
Mouthika,
is
what
what
you told for 13 to 28, you told something, and again 28 to
no
30 something. Huh?
no. See, in patients, if at all they require a cardiopulmonary bypass, you should take such patient for surgery only after 26 weeks of gestation. The ideal time is 26 to 30 weeks.
Okay, in the previous
Because
slide
the
you had
fetal
written some
maturity.
13 to 28. No, what is that for then?
What?
In the previous
Which
slide
is
you had
which?
written 13 to 28 weeks. You had written, no, not this one.
13 to 20. This is the one, no, you're saying.
Correct. 13 to 28 weeks. Correct.
Yeah, that is in the second trimester. Okay. Second
No.
trimester is ideal for any sort of a procedure. It is in general, I'm saying.
Okay.
But the best time to save the fetus or the baby is that after 26 weeks of gestation, the viability is achieved. You got my point? Hello?
No, no, I did not understand. Why?
This is the general time what we say for or a general cutoff what we give for surgery during pregnancy, that is 13 to 28 weeks of gestation. But in this period, more than
This is, I
after
think you meant to say
26
this
weeks,
is ideal from mother point of view, and from more than 28 from fetal point of view, that is better.
yeah.
Okay.
Yeah, because after 26 weeks is the time where the viability of the fetus is achieved. That is the main point. And almost always we have to consider taking a patient for a section, because what they say is prior to a cardiac surgery, we have to deliver the baby and then go for a cardiac surgery, if at all it is feasible, rather than taking a patient directly, with a gravid uterus. Understand?
Okay.
Hello?
Yeah.
Yeah. And the neonatal outcomes basically depends on the gender, the estimated weight based on the gestation, and the steroid use. And timing and mode of delivery in this special population is that the timing basically depends on the cardiac status of the patient and the obstetric evaluation, the cervical assessment, fetal well-being, and fetal lung maturity. So here we can either, in majority of the cases, there are only few named indications wherein we have to take up the patient directly for a cesarean section without any other discussion, and I'll mention them. And rest of all the cases, the patient has to be taken up for a vaginal delivery. And these are the few points which they have mentioned during the vaginal delivery. And in induction, it is safe to use prostaglandins for induction. And what they say is with prostaglandin E1, there is a theoretical risk of coronary vasospasm, but we can still give. And whereas when dinoprost is used, there is a risk for vasodilatation, and hence caution is required when you are giving dinoprost in individuals where decreased systemic vascular resistance is detrimental. So these cautions have to be kept in mind, and you can safely give prostaglandins for induction. And if possible, or when in settings where it is available, where the cervical ripening balloon is available, it can be used. And even artificial rupture of membranes and oxytocin can also be used. And moving on to this vaginal versus section, what the ROPAC study says is that elective section doesn't have any maternal benefit, and it is almost always associated with low birth weights. And what they say is with vaginal delivery, the blood loss is less and the infection rates are less, and the incidence of venous thromboembolism is also less. So as I told, the indication for cesarean section, except for a few, like in patients with aortic syndromes, like in aneurysms of aorta, or previously corrected coarctations, or in patients with outflow tract obstructions, or in patients with this severe failure. These are the few named indications wherein we have to take patient straight away to cesarean section. And except for those indications, in other cases, if there are obstetric indications like impaired descent and all, then we can go for cesarean section. Otherwise, there is no point in taking a patient for cesarean section. So these were the indications which I was mentioning. That is aortic pathology, intractable heart failure, severe PAH, and when a patient is on anticoagulation, the only route of delivery is cesarean section, because there is a very high risk for fetus as well as mother for bleeding. So this is special scenario, that is in patients on anticoagulation. What they say is, in urgent cases, and the patients who are on therapeutic anticoagulation, say, or who patients on mechanical valves and all, the risk associated with the delivery as such is very high. And what they have advised is that it should be tried to reverse the therapeutic anticoagulation with protamine sulfate if possible. And what they have found is that the reversal with the prothrombin complex concentrate is better than with protamine sulfate. And it has to be given based on the body weight and based on the INR of the patient and what is the target INR that has to be reached. And it should be given prior to cesarean section. And the ideal INR for you to take a patient for delivery is less than 1.5. Vitamin K can also be given, but the time taken for it to achieve the target INR of less than 1.5 is nearly 8 to 12 hours. So what they have advised is that whether you can have protamine sulfate or you can use 4-factor prothrombin complex concentrate. But one thing we have to keep in mind is that although you have reversed the mother, the fetus remains anticoagulated at least for a period of 8 to 10 days. And this has to be kept in mind because the risk of bleeding in neonates is very high, and they might need fresh frozen plasma or vitamin K. And that is about the urgent delivery. And those with the planned cases, this is for anticoagulated patients. For planned cesarean section, what we have to do? For planned cesarean section, first thing is we have to omit the low molecular weight heparin, because all patients who are on anticoagulation by 36 weeks of gestation, they will be changed over to low molecular weight heparin. And if the planned section is, for example, say next day or tomorrow, at least 24 hours prior to the surgery, the last dose of low molecular weight heparin has to be stopped. Or if the patient is on unfractionated heparin, 6 hours prior to the delivery, the unfractionated heparin has to be stopped. If the patient is planned for a vaginal delivery, in those with moderate to high risk of thrombosis, we have to convert those who are on low molecular weight heparin to unfractionated heparin, and unfractionated heparin has to be stopped minimum 6 hours prior to the regional anesthesia. And those who are at low risk of thrombosis, we can safely stop low molecular weight heparin 1 day prior to the delivery and restart the anticoagulation with unfractionated heparin after 4 to 6 hours. So this is the protocol which has to be followed. And the hemodynamic monitoring which has to be done. So is there any role for pulmonary capillary wedge pressure monitoring? The guideline says that Swan-Gus catheterization should be avoided. And at max, in patients with pulmonary artery hypertension cases, when they are taken up for a surgery, that is the delivery, we can monitor right atrial pressures. At max, that much can be done. And in high risk cases, it can the hemodynamic monitoring can be done with arterial line. So what happens to the anesthesia? Ideally, in patients where the decreased systemic vascular resistance is detrimental, that is those with outflow tract obstructions, it is almost always advisable not to give epidural or segmental anesthesia, either for cesarean section or for vaginal delivery. Because in these cases, there is every chance of decreasing the systemic vascular resistance, and which is detrimental in these cases. And to counteract the hypotension in these individuals, it can be managed with IV fluids. And the expected decrease or fall in the blood pressure following epidural anesthesia or a segmental anesthesia is around 10%. This has to be kept in mind. And always we have to cut short when you are taking a patient for vaginal delivery. You have to cut short the second stage of labor, and you have to go for forceps and ventouse. And this is the thing where the patients who are on anticoagulation, for a baby, there is a very high risk of developing what you call cranial hematoma. Hence, those babies who have to be continued on anticoagulation, like those who are on mothers who are on mechanical valves, it is almost always advised to take those patients for cesarean section, because in order to avoid this. And what is this? What is the role for perimortem cesarean section? That is, in a life-threatening maternal event, immediate delivery is advised. This delivery is advised because in order to give time for or give space for resuscitation. And it is usually considered after 24 weeks of gestational age. And whatever the cesarean section, it has to be performed within 4 minutes of cardiac arrest of the mother. And postpartum of giving oxytocin is safe in individuals with heart disease, and even prostaglandins can be given. But two things have to be absolutely avoided. That is prostaglandin F and ergometrin. Prostaglandin, I meant prostaglandin E can be safely given, but not the prostaglandin F. Sorry. And the other measures like leg care and early ambulation has to be taken care of. And this 24 to 48 hours period, which I mentioned, patients have to be absolutely and strictly under hemodynamic monitoring to watch for decompensated heart failure. And regarding breastfeeding, the guideline says that lactation decreases bacteremia. And if at all lactation inhibition is required, in a few cases where the mother has to be put on some drugs which causes effects on the baby, in such scenarios, we can use cabergoline or bromocriptine as lactation suppressants. So a brief note on infective endocarditis. So the maternal and fetal mortality with infective endocarditis is 30%. And the most common pathogen to cause infective endocarditis in a pregnant woman is Streptococcus viridans. And the most common valve to be involved is mitral valve, followed by aortic valve. According to the guidelines, so for patients with previous heart condition, except for those with a prosthetic valve or unrepaired cyanotic congenital heart disease, no other underlying heart disease has been deemed as an indication for antibiotic prophylaxis. So only those with prosthetic valve, unrepaired, or complex cyanotic congenital heart disease, these are the only three group of patients where antibiotic prophylaxis is recommended. And there is no specific hygiene or asepsis measures as such recommended to prevent infective endocarditis. This is important. And so yeah, and the other parameters are same as for peripheral embolization, acute regurgitations, or same as for that of non-pregnant women. And one thing regarding the treatment, while selecting an antibiotic, in addition to culture sensitivity, we have to look even into the fetotoxicity. This is one specialty for this group of patients. And the safe antibiotics in all trimesters or beta-lactams, dactomycin and erythromycin. This is, I'm saying this as a broad classification, but there are individual drugs recommendations. And fetotoxicity, which is seen in all trimesters and which has to be avoided in all trimesters, is aminoglycosides and tetracyclines. So moving on to individual disorders. First, I want to deal with congenital heart disease and pulmonary artery hypertension. I didn't go into details of everything, whichever, I have briefed them here, majority of it. The most common congenital heart disease, usually all this repaired simple congenital heart disease like VST, AST, and even PDA, if at all it has been repaired and there is no residual shunt, even in unrepaired cases of AST, they're usually well tolerated. And the factors which determine the risk or the type of congenital heart disease, the underlying systemic the function of systemic ventricle, the functional class, and the cyanosis. With onset of pulmonary artery hypertension, the mortality in mother, it ranges from 60 to 30%, and it is the same even for the fetus. It is around 30%. So the presence of pulmonary artery hypertension accounts for both maternal as well as fetal risk, accounting nearly 30 to 50% is what they say. In different studies. And to avoid pregnancy, usually in the presence of PAH, pregnancy has to be avoided. And if at all it was not possible, or you are seeing for the first time the patient with the PH on a pregnancy visit, it is almost always advisable to go for a termination. And the greatest risk period with in individuals to develop complications, that is in individuals with congenital heart disease or with the severe PAH, is in the prepartum period and early postpartum period. And the causes of death in this group of population is mainly pulmonary PH crisis, pulmonary thromboembolism, and acute right heart failure. So how these patients have to be managed? They have to be put on anticoagulation, diuretics in the event of a heart failure, and always iron deficiency have to be corrected. And it is advised that rather than a stepwise protocol for pulmonary artery hypertension, it is advised to go for early combination therapy. And it is always advisable not to go for endothelin receptor inhibitors, that is they are teratogenic, so they have to be avoided. A few words on Eisenmenger's syndrome. The maternal risk basically depends upon the cyanosis and the right to left shunt and presence of paradoxical embolism. Why Eisenmenger's is bad in pregnancy is because in pregnancy there is decreased systemic vascular resistance, which leads to increased right to left shunt, which actually worsens the cyanosis and decreases the cardiac output. And as I mentioned, the maternal mortality ranges from 20 to 50%. And it is always advised to go for a termination, even though the termination is associated with risk. It is not free of risk. Even the termination of pregnancy is also associated with risk, but the risk associated with termination is less when compared to this full gestation delivery. And the fetal risk is mainly related to the maternal cardiac output and cyanosis. Most commonly, miscarriages are seen. And hypoxemia is the important predictor of outcome. Hence, the saturation of the mother, if at all it is more than 90%, the amount of fetal loss was observed was in only 10% of the cases. When the saturation is less than 85%, the fetal loss was as high as 90%. This is one thing which have to be kept in mind. And how these patients are managed. So, they have to be put under anticoagulation, but the main problem with anticoagulation is that there is high chances of thrombocytopenia and decreased vitamin K dependent clotting factors. So there is also a high risk of bleeding when these individuals are put on anticoagulation. That has to be kept in mind. And when the PAH treatment per se, which is safe in pregnant women, is that sildenafil and prostanoids can be used. So what are the recommendations for patients with PAH? Is that right heart catheterization for the diagnosis of PAH is a class 1 indication in pregnancy, and the treatment with low molecular weight heparin for patients with CTEPH is a class 1 recommendation. So, and pregnancy is not recommended in patients with severe pulmonary artery hypertension, and it is a class 3 recommendation. Whereas in congenital heart diseases, this is important, that is in patients with systemic right ventricle, those with NYHA class 3 or 4 or 3 or above, and when the systemic ventricular function is less than 40%, and in the presence of severe TR, they have to be advised against pregnancy. They come under WHO class 4, where the pregnancy is almost contraindicated, and the anticoagulation is advised in patients on Fontan circulation. And in patients with Fontan circulation where the saturation is 85%, again the pregnancy is contraindicated. So this is a brief note about individual disorders. I think we can go through this. I've charted down here. And moving on to aortic diseases, which are important in pregnancy. They are like again syndromic and non-syndromic. Syndromic being Marfan's, Loeys disease, osteoaneurysm syndrome, vascular Ehlers-Danlos syndrome, and Turner syndrome. Pregnancy has a high risk for patients with aortic pathology, and the pathology behind this is that increased estrogen levels leads to dilatation of the aorta, mainly by increasing the protease activity in the extracellular matrix, whereby there is a defective collagen synthesis leading to laxity of the vessel. This is the reason why in already in predisposed individuals, like in fibrinolopathies, like in Marfan syndrome, where the connective tissue is abnormal, this extra stress offered by the increased estrogen levels lead to extra laxity of the vessel, and there is every chance of dilatation, dilatation and aneurysm, as well as rupture or dissection are very high in patients with aortic disorders. A few points about Marfan's. In Marfan syndrome, the aortic dimensions will not revert to pre-pregnancy levels, and what they say is that in Marfan syndrome, pregnancy actually worsens the natural history of Marfan syndrome. That's what they say. And because the aortic events, or the risk for developing future aortic events is very high. The aortic size is the major risk factor, and less than 40 mm, the risk of dissection is 1%, whereas more than 45 mm, pregnancy is contraindicated. Even though a patient has undergone a repair for aortic dissection, is the patient free of future events? What they say is there is every chance of developing another event, even though not in the same location. It can happen in other locations, usually in distal aortic location, and involvement of other vessels is what they say. And other complications apart from aortopathy in patients with Marfan syndrome, or like mitral valve prolapse, new onset of arrhythmia, and heart failure. Second common aortopathy is in association with the bicuspid aortic valve, wherein the cutoff of more than 50 millimeters aortic dimension has been put as a contraindication for pregnancy, and aortic dilatation less than 50% can safely go through the pregnancy. And it usually bicuspid aortic valve is usually associated with distal ascending aorta aneurysm, and it is often missed in echocardiography, and hence the class 1 recommendation for patients with iotopathy or at risk of iotopathy or a family history of iotopathy or genetic association has been found is that in patients with iotopathy, the imaging of entire aorta is a class 1 recommendation, because and it has to be done either with MRI. So this is to summarize the iotopathies in pregnancy. One thing here I want to mention is that in vascular Ehlers-Danlos, the visceral rupture is very common, and as such, pregnancy is a contraindication because the risk of uterine rupture is nearly 50% in this group of patients. And the second thing is that when you're taking a patient for parturition, if, going with regional anesthesia, that is spinal anesthesia, these patients, like those with Marfan's, Loeys-Dietz, and Turner's, have dural ectasia, and it has to be kept in mind that the risk for regional anesthesia in these individuals is very high. So these were the cutoffs which I mentioned. And in Turner's, the aortic size index, that is the aortic size which is indexed to the body surface area, has to be taken into account. And aortic size index more than 25 millimeters per meter square is the cutoff. And few studies have found that even in as low as less than 20 millimeters per meter square aortic size index also, there were incidences of aortic dissection in patients with Turner's. But according to the guideline, it is more than 25 millimeters per meter square is contraindication. So these were the recommendations. I just want to concentrate on only few. Like, so in patients with ascending aorta, when the dimensions are less than 40 millimeters, we can safely go ahead with vaginal delivery. But those with more than 45 millimeters, cesarean section has to be considered. And between 40 to 45 millimeters, the cesarean section is a class 2B indication. So these are the only few points, and I think we can go through other things. And I mentioned this MRI. MRI is a class 1 indication. And one thing we have to see here is for follow-up of the aneurysm size, we have to follow up these individuals every 4 to 12 weeks, depending upon the size and depending upon the rate of increase in the aneurysm. And it is recommended that these have to be followed up every 4th weekly or 12th weekly with echocardiography. And the follow-up has to be continued till 6 months postpartum. That has to be kept in mind. And the vascular Ehlers-Danlos, as I told, it is a contraindication for a pregnancy. But if you are encountering a patient with vascular Ehlers-Danlos, we can put them on celiprolol. It is a beta blocker, which has been recommended for only this indication. And in patients with Marfan's who have been initially on beta blockers, in pregnancy, beta blocker has to be continued. That is one thing very important. So, so these are the various societies' recommendations for the size of the aorta and the contraindication and indications for pregnancy. So moving on to valvular heart disease. So these are the common valvular heart diseases, whether being acquired or congenital. In our situation, it is rheumatic, which is more common. So whatever may be the valvular heart disease, whether it is stenotic or regurgitant lesion is what is important. Usually, the stenotic lesions of mild to moderate severity are well tolerated in pregnancy. And aortic stenosis is well tolerated when compared to mitral stenosis. And among the regurgitant lesions, again, aortic regurgitation is better tolerated when compared to mitral regurgitation. And when compared to stenotic and regurgitant lesions, as I told, regurgitant lesions are better tolerated than aortic lesions. I mean, stenotic lesions, sorry. And among the severe regurgitant lesions, severe mitral regurgitation in pregnancy is associated with bad outcomes when compared to aortic regurgitation, because the LV size increases, and which actually begets MR. Hence, in patients with severe MR who are pregnant, there is every chance of them going for decompensated heart failure during pregnancy, and this has to be kept in mind. A few points about aortic valve disease, that is aortic stenosis, as I told, mild to moderate or well tolerated, and then severe aortic stenosis. We see higher chances of heart failure, increased incidence of arrhythmias, and increased incidence of prematurity, and all of them contributing to shorter duration of pregnancy. One thing which has to be kept in mind is that the blood loss has to be avoided, because blood loss is associated with maternal collapse and even the epidural and spinal blockade. As such, the decreased or hypotension should be avoided in patients with aortic stenosis. And what happens to mitral stenosis? Mitral stenosis, because of a decreased forward flow, that is decreased stroke volume, leads to increased heart rate. And as such, in pregnancy, there is increased plasma volume. So this increased heart rate and increased plasma volume actually increases the flow across the valve, leading to increased gradient across the valve and increased LA pressures and pulmonary venous hypertension in these individuals. And there is every propensity or chance to develop pulmonary edema and atrial arrhythmias in patients with mitral stenosis during pregnancy, because it is it actually challenges the hemodynamic. Increased hemodynamics actually challenges the valve during pregnancy. And these are the indications which have been described. So it is always advised in patients with severe MS in the presence of SEC, even though the patients are in normal sinus rhythm, we have to go ahead with anticoagulation rather than deferring anticoagulation in this group of patients, because as such, pregnancy is a hypercoagulable state, and above that, presence of MS, severe MS, severe MS in the presence of SEC in the LA, even though there is no signs of embolization, still we have to put the patient on anticoagulation. And beta blockers or class 1 recommendation in mitral stenosis in pregnancy. And in the presence of congestive symptoms, diuretics are again a class 1 recommendation, although diuretics are associated with fetoplacental insufficiency, but still they are class 1 only in the presence of congestive symptoms. And patients with severe MS or WHO class 4, that is pregnancy is contraindicated. If a woman is contemplating, wants to, go for consumption, then it is almost always advisable to go for pre-pregnancy mitral valve intervention if the valve area is less than 1 centimeter square and the patient is symptomatic and the pulmonary artery pressures are more than 50 millimeters of Hg. Almost always it is advisable to go for pre-pregnancy intervention, and post intervention the patient can safely go for pregnancy.
Mouthika,
And yeah.
hello. What you told?
Yeah,
you told that if there is also grade 3 SEC, they should be anticoagulated. Huh?
Yeah, they have to be anticoagulated. This is in ESC. Yeah.
Where is
ESC,
it?
ESC.
No, but
ESC 2018 pregnancy guidelines.
Okay, here it's not mentioned. That's why I was okay. Fine.
Yeah. They said anticoagulation has to be considered because pregnancy itself is a hypercoagulable state, and there is every chance of systemic embolization in these individuals. Is what they have mentioned.
In this screen, it was not there. That's why I thought I'd ask. Okay.
Yeah, fine, no issue. And during pregnancy, if the patient is symptomatic and if the pulmonary artery systolic pressure is more than 50 millimeters of Hg, then and if the patient is after 20 weeks of gestation, we can take the patient for PTMC with all the risk explained. And so I think these are the indications for aortic stenosis intervention. Moving on to the prosthetic valves. So bioprosthetic valves are less thrombogenic, but they are more prone to degeneration, and pregnancy usually do not have any effect on rate of degeneration of the bioprosthetic valves. So it was a misconception before that in pregnancy, the bioprosthetic valve undergo degeneration faster, but it has been observed that there is no such rapidity of degeneration in pregnancy. And there is very few data on the Ross procedure. If possible, we can go ahead with Ross procedure in patients with instead of mechanical valves. And it has been observed that the hemodynamics are good with Ross procedure, and even the outcomes are good with Ross procedure in pregnancy. And a brief note on the mechanical processes. Mechanical processes per se has a very high maternal and fetal risk. The mother is affected both with the thrombotic as well as bleeding risk, and valve dysfunction leading to heart failure chances are very high in pregnancy, because pregnancy, as I told, is a hypercoagulable state, and there is a very high risk for thrombosis in these individuals. And when these individuals are put on anticoagulation, the risk for the fetus in the form of fetopathy or embryopathy are very high. And they have found that the risk is highest during 6 to 12 weeks of gestation for the fetus, and that is with oral anticoagulants. What I mean is, so what they have advised is that during this period of higher teratogenicity, that is between 6 to 12 weeks, it is advised that the oral anticoagulation has to be changed over to heparin. Either it could be unfractionated heparin or low molecular heparin. So if the embryopathy, warfarin embryopathy occurs during 6 to 9 weeks of gestation, and it usually presents with stippled epiphysis or nasal hypophysis. And the warfarin fetopathy is seen throughout the pregnancy in all the trimesters, but highest in 6 to 12 weeks period. And it can happen even in second and third trimesters. And it usually manifests with optic atrophy and CNS abnormalities. So among the unfractionated heparin and low molecular heparin, low molecular heparin was found to be safest because it do not cross placenta. What study says is that even unfractionated heparin can cross, even though it doesn't cross placenta, it can still cause embryopathy. And there is high chances of osteoporosis and HIT with unfractionated heparin. So in pregnancy, it is advisable to go, give low molecular heparin over unfractionated heparin. So in patients with mechanical valves, depending upon the oral anticoagulation dosage, that is, if it is more than 5 milligrams per day or less than 5 milligrams per day, if it is less than 5 milligrams per day, during the first trimester, the patient can still continue to take oral anticoagulation with 2 weekly INR monitoring. This is a class 2A recommendation. Or the patient can be, if at all the fetal well-being was a concern for the mother, then she can go ahead and change over to low molecular weight heparin or unfractionated heparin. This is a choice in patients whose warfarin requirement is less than 5 milligrams. But in patients where the warfarin requirement is more than 5 milligrams or acitram requirement more than 2 milligrams per day, they have to be during the first trimester, that is between the 6 to 12 weeks period, it is almost always advisable to put these individuals on heparin. So that is the reason why they have divided into 2 groups. And following which, the patient can be continued on vitamin K antagonist, that is warfarin, till 36 weeks of gestation. So once the patient is at 36 weeks of gestation, the patient has to be again changed over to heparin. And as I told, the heparin can be low molecular heparin or unfractionated heparin. If at all it is low molecular heparin, depending upon the delivery status or the choices which have been made, it can be changed to unfractionated heparin or it can be stopped depending upon the thrombotic risk. That's what these 2 tables says. So how to monitor them? Oral anticoagulation, as I told, 2 weeks once, it has to be monitored. And when you are giving unfractionated heparin, it can be monitored with APTT or with factor 10A levels. And as all of us know, the factor 10A levels has to be measured 4 to 6 hours after the dose, and it should be maintained at a level of 0.8 to 1.2 international units. And even the trough level has to be taken, and the trough level should be more than 0.6. And these are the recommendations. I think we can go through this. So what are the target INRs? It basically depends on the thrombogenicity of the mechanical processes and also the patient-related risk factors. So what are the high risk behaviors or high patient-related risk factors? They are like mitral or tricuspid valve replacement, previous thromboembolism, atrial fibrillation, mitral stenosis of any degree, and EF less than 35%. So based on this and based on the processes which has been used in the patient, in low thrombogenic processes, and in the absence of a risk factor, patient risk factor, the INR can be maintained at 2.5, and if at all risk factor is 3, I mean, if more than one risk factor is there, it has to be maintained at 3. So based on this, the range is 2.5 to 3, 3 through 3.5, 3.5 to 4. So that's in brief about the valvular disorders in pregnancy. And moving on to the ischemic heart disease in pregnancy. It could be because of spontaneous coronary artery dissection, could be because of atherosclerosis, and could be because of mouthika. The most common cause for coronary artery disease in pregnancy is spontaneous coronary artery dissection, and it is it was observed that the incidence of atherosclerotic disorders are on increase because high risk women like hypertensive, diabetes, and hypertriglyceridemia or hypercholesterolemia women going into pregnancy is very high. Is very high, and the highest risk in these individuals was seen in the third trimester and postpartum, and the incidence of congestive cardiac failure is 40% and arrhythmias being 12%. As Praveen has discussed, the most common artery to be involved in spontaneous coronary artery dissection is LAD. What is the proposed mechanism for spontaneous coronary artery dissection in pregnancy? They found that the fluctuating levels of estrogen and progesterone leads to abnormal vessel integrity in the background of FMD or connective tissue disorders, and also there is increased shear stress during labor. These are the two mechanisms which have been proposed, and they also have found that the increased survival in Kawasaki patients have also presented with spontaneous coronary artery dissections or other coronary artery events depending upon what is the coronary anatomy prior to the pregnancy. If at all the Kawasaki patients had persistent aneurysm or stenosis, or depending upon the type of underlying lesion, they can present. And when do these cases present? Commonly in the third trimester or in the postpartum. In third trimester, the STEMI rates were 25% and NSTEMI was 32%. In postpartum, it was STEMI was 45% and NSTEMI was 55%. And in patients with pre-existent coronary artery disease, what happens to the pregnancy? A pregnancy can be considered in the absence of a residual ischemia and a normal functioning LV. And if at all a patient had a recent ACS, it is advised that pregnancy can be contemplated after a year following an ACS event. And there is no evidence of recurrence of spontaneous coronary artery dissection in next pregnancy. What happens if the patient develops MI intrapartum? It is advised that delivery has to be postponed by at least 2 weeks because time has to be given to the mother for medical management of ACS, and it is always advised to go for vaginal delivery. So this is the management protocol. if, as I told, SCD is SCAD is the most common form of coronary artery involvement in these patients. Depending upon the high and low risk features, the patient can be taken up for the intervention. And the class 1 recommendation is a primary PCI. A patient presenting with STEMI has to be taken up for a primary PCI. What is the role for thrombolysis? Thrombolytics can be given in very high risk patients wherein they cannot be taken up for procedure because, but with a very high risk for placental bleeding or even maternal bleeding. But one thing what we have to remember with fibrinolytic is that they do not cross placenta. They are large molecules and they do not cross placenta. And obtaining ECG and troponin levels is a class 1 recommendation. What happens to NSTEMI? In patients with low risk NSTEMI, they can be managed with the conservative strategy. If at all there is a high risk NSTEMI, they can go ahead with invasive strategy. And a follow-up after 3 months is a must in these individuals. And one thing I told you, this is one scenario wherein breastfeeding is not recommended because patients are put on anticoagulations and antiplatelets who have been taken up for a PCI. So moving on to the cardiomyopathy and heart failure. Here I just wanna emphasize on acute management of heart failure and conservative management of heart failure. So in patients who presents with acute decompensated heart failure, based on the hemodynamic parameters of the mother, if at all the mother is hemodynamically unstable, and look for the viability status of the fetus. If this, irrespective of the viability status of the fetus, delivery has to be conducted because that is a must, because we have to maximize the advanced heart failure in these patients. So if at all the fetus is viable, we have to go ahead and deliver the baby. If at all, even if it is not viable, we have to terminate the pregnancy and take the mother for advanced heart failure measures. That is important. And what happens to stabilized heart failure? In patients with stabilized heart failure, patients can be given nitrates, hydralazine, beta blockers, and diuretics. And what has to be absolutely not given in these patients is AC inhibitors, ARBs, mineral corticoid antagonists, and ivabradine. These are an absolute contraindication. And what happens to mechanical circulatory support? As I already mentioned in the peripartum cardiomyopathy, these patients can be taken up for mechanical circulatory support if at all the hemodynamics are not maintained with inotropic support. And one note on the bromocriptine in patients with peripartum cardiomyopathy. When a patient is put on bromocriptine, it is always almost advisable to put them concomitantly on anticoagulation because prolactin is a scavenger of thrombin. What bromocriptine does is by decreasing prolactin, it increases the levels of thrombin and hence the thromboembolic risk is very high. So when a patient is put on bromocriptine for as a part of treatment protocol in peripartum cardiomyopathy, they have to be anticoagulated irrespective of presence or absence of clot. So this is the board strategy which they have mentioned in the guideline. I just want to mention here. So quickly moving on to the arrhythmias. The most common arrhythmia is SVT and AVNRT being most common. In pregnancy, recurrences are common. The occurrence of the first event is uncommon in patients with in pregnancy. And almost always we have to rule out underlying structural heart disease, and presence of structural heart disease is not that common in patients with PSVT. And they have to be approached initially starting with vagal maneuvers followed by adenosine and later on by nodal blocking agents. Beta blockers and calcium channel blockers can be given, but always you have to watch for the development of hypotension. And as an alternative, we can even give procainamide in these individuals. If there are frequent recurrences, then as a maintenance therapy, they can be put on beta blockers or digoxin. In the absence of structural heart disease, even we can consider sotalol, flecainamide, or propofol. But amiodarone is an absolute contraindication because amiodarone was found to have a 17% fetal hypothyroidism risk. And a small note on AF. Occurrence of AF in pregnant women happens in the presence of a structural heart disease. And what are the risk factors for AF in pregnancy? Or a prior history of AF, and presence of mitral or aortic valve disease, or presence of left-sided cardiomyopathy. If they are hemodynamically unstable, patient has to be taken up for electrical cardioversion. In stable patients, when accessory pathway has been discerned, we can safely give procainamide. And in structurally normal heart, you can give epitolite or sotalol. Anticoagulation is almost always indicated. What happens to VT? We have to rule out first a structural heart disease. In a structurally normal heart, the most common form of VT is outflow tract VT. And one thing we have to remember here is that peripartum cardiomyopathy can also present as new onset VT, especially in the last trimester. So this is a management protocol which has been advised. But one thing here, this is from the Hearst, but the recent guidelines doesn't mention anything regarding lidocaine. They don't mention anything regarding lignocaine, that is the ESC 2018 guidelines. So these are the guidelines regarding the management of patients with arrhythmias, which I have mentioned the same thing they have given here. And moving on to the hypertensive heart disease in pregnancy. They are mainly of preeclampsia, eclampsia, chronic hypertension, and chronic hypertension superimposed on preeclampsia. And I think everyone knows how to, differentiate these. I just want to mention these few points. Like, so what are the risk factors for development of preeclampsia? Those being CKD, autoimmune disorders, previous history of hypertensive heart disease and diabetes and chronic hypertension. One thing here I want to mention is that high and moderate risk individuals have to be put on 100 to 150 milligrams of aspirin from 12th week to 36 weeks of gestation. And they mentioned one thing about the calcium supplementation. 1.5 to 2 grams of calcium has to be given in those individuals where the calcium intake was found to be less than 600 milligrams. And there is no role for vitamin supplementation. So these are the guidelines regarding that. And what happens to venous thromboembolism? The risk of venous thromboembolism is very high in the immediate postpartum period, and the risk decreases to pre-pregnancy level by 6th week postpartum. It is 5 times more common in pregnancy, and the highest risk being a previous history of venous thromboembolism, history of thrombophilia. And in 1/3 of the cases, it is usually asymptomatic. So a high index of suspicion is required. The risk of sudden cardiac death in individuals with venous thromboembolism is 4%. And the indication for IVC filters is same as for non-pregnant individuals. So this is the brief flow chart. This regarding the treatment, as all of us know what has to be given and what should not be given. Ideally, oral anticoagulation, NOACs are avoided, and even that is the direct thrombin inhibitors are avoided. Heparin has to be given. And this is one new entity, that is cerebrovascular diseases of pregnancy. I'm not going into details. I think you can go through the notes, but this has been mentioned in the 2020 guidelines. And what happens to dyslipidemia in pregnancy or hypercholesterolemia in pregnancy? Normally, the total cholesterol, triglycerides, and LDL level increases during pregnancy, and they reach a peak at delivery. Normally, it do not go beyond 250 milligrams per deciliter. And these are the primary and secondary causes for hypercholesterolemia. These are the guidelines which they are mentioned for familiar hypercholesterolemia and hypertriglyceridemia patients. Because statins are contraindicated in patients with pregnancy, They can be started on bile acid sequestrants, mipomazole, and LDL apheresis during pregnancy and during lactation. That's it. I thought to mention even the pregnancy PTMC, but I thought it would be even more lengthy than this, but it's hardly 1.5 page. I'll add the notes and I'll update. Hello? Anybody still there?
Yeah,
Yeah,
Mouthika,
okay,
you're all
okay.
here.
Thank you.
Sorry.
No, I think
Mouthika,
we can, like you said, you can just add it later. It'll maybe just cover one page, so it's okay.
Yeah, hardly 1.5 page.
Extensive,
Yeah.
exhaustive, madam.
Sorry.
Thank you,
Quite
Mouthika.
boring.
Nice presentation, nice compilation.
Yeah.
Thank you.
Thanks,
Thank you.
Mouthika,
Yeah.
voice. Hello.
Hello,
Hey, ಕೇಳಿಸ್ತಿದೆ?
Gautam, tell man.
ಏನಿಲ್ಲ.
ಗೌತಮ್
Hey, ಇದು any extent of
ಗೌತಮ್ ನೀನ್
age is
ಗೌತಮ್ ನೀನ್ ಹಲೋ ಹೇಳೋದು ಬೀರೇಶ್ ಸರ್ ತರನೇ ಇದೆ ಗೌತಮ್ ಎಕ್ಸಾಕ್ಟ್ಲಿ
oh yeah